allowing me to have. Okay. Recurrent is the one allowing me to have my voltage high. But remember, I'm Doom. She was worried about her recurrence? No. She was worried about the external, believe it or not. So unless if you are a soprano singer, somebody who is constantly with a high note, constantly speaking, not a physician teacher, that's where you need your external. But believe it or not, she wasn't worried about the recurrence. And it's external even overlooked. So you are perfectly medically getting fine, say, I did the thyroid surgery, I tied the upper fold, this is thyroid. I don't have to document that I've seen the external. Well, I'm fine if I've seen the external. 20% of cases I don't see and it's okay. Recurrent has happened. Okay. So this is all about anatomy. Parathyroid, there is 4 parathyroid glands. في ميوت بدي اعمل له ميوت بالله عشان في اوفر فويس عليها. كيف ممكن اعمل ميوت هنا؟ بس خلاص. 4 parathyroid glands, they are in close proximity of the thyroid, so they could be injured. But take home method. You all of you when you graduate, you will function with insurance. So any patient coming or you suspect a thyroid disease, you have to screen them with TSH. You don't go for T3, T4 unless if you are looking for something specific and you're suspecting Hashimoto and the TBO level. Okay, this is the 2 things you need to remember, no matter what your specialty. The problem with thyroid, the patient gonna present with one of 2 ways. They either could come together or they could come alone. Okay? So either the patient will come and tell you, hey, I have anatomical dysfunction. So I have neck lump. I've noticed that. My family, my friend noticed that. Or how is that lump? Maybe not visible, but gonna affect the adjacent organ. So what's the adjacent organ we just mentioned? So if it's breathing on the trachea, will give you what? Difficulty breathing, especially when they lie down. If it's breathing on the esophagus, if it's breathing on the nerve, dysphonia, hotness, okay? And sometimes if it's breathing on the nerve, it may have an ear pain, because it's a referred pain. Okay, so this is the pure anatomical. There's a problem. Rather than a certain side, you have abnormal nodules getting bigger. This is the anatomical. Functional, too much or too little thyroid. You may have functional and anatomical, or only anatomical, or only functional. Okay, surgeon, we don't usually that much deal with functional, except in the cases of resistant hyperthyroidism, thyrotoxicosis. Like on Thursday, I have this case, inshallah, we'll do a total thyroidectomy because this guy had thyrotoxicosis. He got febrile neutropenia as a side effect of carba, and the only way to give him now with the uncontrolled thyrotoxicosis to control his thyroxine is, okay? So usually we deal with the anatomical dysfunction and the related to anatomical dysfunction, like cancer. But the function, unless it's uncontrolled thyrotoxicosis, we don't deal with that as a surgeon. We endocrine deal with that. Okay? So this is the most important thing. Patient presents to you with a palpable thyroid nodule. What do you need to do? 2 questions, don't forget the history. Because it's gonna make a difference in your decision. 2 most important questions gonna make me change my mind about the FNA or not. We're gonna come to it if you not focus. With 2 questions you don't cannot see. So history, physical examination, TSH measurement and screening, and to make your life easy. This is what order ultrasound, this is order CT scan. Written in the front, we always like ultrasound. Rarely we order in CT or MRI. Rarely. I'm not saying that, but rarely. Okay? So ultrasound. If I had the TSH suppressed, that means the thyrotoxicosis. Here I'm gonna order radial scan, a radioactive scan. TSH is normal or high. If I have the thyroid nodule, they change it. 1.5 centimeter, anything 1.5 or above must be have ultrasound guided FNA. Good. Anything less than 1.5, they say here, with a risk factor. So what risk factor? Yeah, going back to the history. What risk factor will make me FNA below 1.5? Family history, how much will I get increase it? 7 times. Nothing. Nothing in the whole history of cancer runs in family like thyroid. Like the fact you had a single family member with thyroid CA, luckily, it runs in family. Luckily, it's a thyroid CA, which is a treatable cancer. Luckily, the other cancer doesn't have this affinity. Luckily, in one way, at least the thyroid cancer, it's absolutely treatable disease and an easy, no consequence, no major consequence with that, not like the other cancer. So 7 times. Family history, I will FNA. Other history, radiation. Although it's no longer that much used, but radiation to the head and neck area will increase the risk. Okay? So, other things you need to know, the thyroid system. I think on the breast lecture, I will get to talk to you about thyroid system. So thyroid system is a radiological. You don't need to know the detail about it. You don't need to know the details about it. But please know the thyroid, it's a radiological scoring to tell me how suspicious is this nodule. The higher the number, the worse. Easy? Okay. If they give me anything, the ultrasound guided aspiration, they're gonna come and tell me, and don't rely on this because I'm gonna update this one. The FNA result will come and tell me if it is the 1, 2, 3, 4, 5, or 6. That's basically the result, and you have to make a decision. Life is easy. 1 or 2, benign. Benign, do I have to do anything? Usually not. Usually not. Okay? Unless if it's benign, I don't usually touch it. Any benign things, logically, I don't need to touch it unless if I don't believe in this. So we have to remember one thing in medicine. There's nothing 100%. Even when I say it's benign, I'm 92 to 94% confident that it's benign. But there is 6 to 8% acceptable error. That's it. If I think there is something else indicating the 6 and 8, it's slightly high, then I may need to do intervention. For example, this magic number, we like it in a person in the time, 4 centimeters. Anything above 4 centimeters, take it out. Why? Even if it's benign. The patient will come to me with a breast lump, thyroid nodule, 4.5 centimeters, breast lump with 4.5 centimeters. I biopsy it, benign. So why would I take it out, though? So the risk of malignancy, how much it is? The risk of being accurate, how much it is? So I'm accurate only 80%. Okay? So 80% being 20% off, that's unacceptable. So 20% error in medicine unacceptable. I'm accepting 6 to 8, but 20% anything I'm in doubt as a rule of thumb. In medicine, it's applied everywhere in medicine. I think there's a 20% chance being malignant, it's out. So when it's 4 centimeters and above, we don't think so the FNA is enough to sample the whole thing. So maybe it's missed something. So anything more than 4, you find us taking it out, it's fine, it's benign. I know it's benign, but I have to take it out because it's above 4. So because I'm 80% confident. Okay? So overall benign, it's obvious I'm gonna leave it, except if I didn't think it the actual benign. So here I'm gonna intervene. I'm not gonna get into details because it's beyond you, but try to apply this rule everywhere else. Why I need to remove something benign? Because I'm not 100. We would think investigation is 100%. No, the best investigation to sensitivity and specificity 92, 94%. There is always 6 to 8% wrong, and that's acceptable. Medicine, we don't accept 20% error. Too much. Too much. Okay? 5 or 6, 6 is cancer. Out. 5 is unlikely cancer. Out. Lovely. Now the problem with the indeterminate, the 3 and 4. 3 and 4 is simple as that. It's like the pathology will tell you that is abnormal. So there are some abnormal cells. Are they cancer? I don't know. Are they benign? I don't know. So you have to put it all together with a risk factor, with a thyroid presentation, and either observe and repeat FNA or do diagnostic lobectomy. Okay? Diagnostic lobectomy means I'm removing the whole lobe and see if it's cancer or no. Parathyroid is not you. So, what type of a surgery I do? Thank you so much. I can't thank you enough. There is nothing called subtotal nowadays. It's still in your textbook. Nowadays, it's no longer subtotal. When I was your age, it used to do subtotal. HME subtotal, they leave part of the thyroid over the parathyroid and the nerve. And that's excellent for in terms of saving the parathyroid and the nerve. Amazing. Okay, because you decreasing the rate of injury, you keeping some thyroid tissue, so the patient doesn't need that much of a replacement, so that is good. But what is the problem with that? The problem is we are operating on young people, they live 20, 30 years, and they have a recurrence, and now the rate of injury, rather than being 1%, I'm talking a little sign of 15, 20%. Because it's a fibrosis, so we stop doing that. So it's either total thyroidectomy or hemithyroidectomy. We stop doing subtotal. Okay? I mean, subtotal, I have to justify. Even in the, I said, oh, it was so stuck to the nerve. I thought I cannot preserve the nerve. If I try to remove it from that nerve, I will injure the nerve. So I left some tissue on the nerve. Okay? That I have to justify why I left some tissue there. So either I'm doing hemi or full, either I'm removing the central lymph node or the central and lateral. If I ever the disease, cancer, went there laterally, it must go through the central, so I have to remove it. Simple as that. Even if I don't have an evidence there. So either I'm doing the thyroid alone or the thyroid with the lymph node. And the thyroid either all or half, and the lymph nodes either I do nothing or I take central alone or I take central and lateral. If I did lateral, I'm obligated to do central. Okay?
I didn't get the central. I didn't get the central.
Central lymph node is the lymph node, it's called 5 and 6, is the one behind the thyroid. So if ever the cancer, we go there if there's a cancer. Went to the lateral part, it must go through here, even if I don't have an evidence, so I remove it.
Why did we stop subtotal?
Because the rate of recurrence is so high and then it's not justifiable that exposing the patient to the risk of recurrent nerve injury. Because I'm operating on young people. Thyroid is a disease of young people. Usually I'm operating on people 20, 40. So they live up to 60, 80. Then it's totally not justifiable. Okay? So what is the side effect of thyroidectomy? Let's go to the anatomy. So what do you think is the side effect? Okay, what else?
But what is the problem could happen? What is the problem could happen? Or what is the problem could happen? Or what is the complication around this type?
Yeah. So bleeding, what will happen if I got bleeding? No, I wish if it's shocked. I wish. It's literally a suffocation, so immediate death within 2 to 5 minutes max. How big is the neck? I need the biggest neck ever. Filled with what? Trachea, esophagus, tight muscle, and the brain, tight muscle. Okay. Lots of big important nerve and vessels, but you need only 10 ml. 10 ml is not a blood work to obscure that area and collapse the trachea from outside. 10, 15 ml, nothing like that. And abdomen, I will lose liters. You have to walk, you have like 400 in this abdomen. We'll give him some blood. Up. Chest. Do I even bother to put a chest tube before 500 ml? Because the small hemothorax. Okay. That's what resort. Don't even bother even with a chest tube. Then 10:15. And it's one take home message. I mean it. When we have bleeding post-thyroidectomy, it's bedside. Wall sterilization, nothing. You grab the nearest gloves, disposable, sterile, anything. Knife, up in the strap muscle, up in the skin, get the hematoma out. Then we run to the OR and control the bleeding. Bedside. There is a famous case 3 years ago, Kullu students are told, they are aware of that. It's literally, post-thyroidectomy patient have a bleeder. They called the junior resident, he was hesitant to do so till he called his senior, taken 12 minutes, explained that the patient, at least till the last year, he was still in a vegetative state. No joke. No joke. No sterilization, nothing. Knife up in that wound, get that hematoma around that trachea, patient could breathe. Now we're gonna go to OR. We'll wash, we'll sterile, we'll find out what was bleeding, then control that bleeding, and check the nerve, and do the appropriate things, and put the drain, and close the things appropriately, and cover the patient with antibiotics. But we have to save his life. It's a life saving. So this is a life saving. You literally could get somebody to be dead or brain dead, which is one. So bleeding here, and we took the GS, there is practically from that from at the moment. Okay, let's use. Thank you. Cinema, doesn't take much. Cinema, let's enough with help, survive. Okay, so bleeding here is something. What about the other complication? Damaging the nerve, so what will happen?
What's next? What is minus?
That's literally their cause. That's the recurrence. What about the external? The external is on Okay, so fatigue. So they will not be bothered unless they are using their higher note or they are talking so much. And are having clinics, مثلا, at the end of the clinic will be tired. Teacher at the end of, they will be tired. Or sometimes sensory dysphagia, but usually the other will compensate. So then when they eat bulky things like meat, shabura, they will. I need fluid available. That is bit of dysphagia. Okay? So nerve damage. What else there?
Removing the parathyroid.
Parathyroid. Which is worse? Removing parathyroidectomy or recurrent laryngeal nerve injury? True, parathyroid. Parathyroid is a huge morbidity. They will be at a high calcium and they're feeling low and feeling tired and fatigued. High calcium, high vitamin D. They're talking about doing pH replacement therapy. Okay, but yeah, still not yet. In the market. Excellent. Okay, so recurrent, you enter one side, till the other side up to 80% could compensate, and he doesn't need intervention. There's lots of intervention that happen. If it's bilateral, will close. What will happen? Suffocation. So they need the trade.
How common is it?
If you are an experienced 1%, 0.5 to 1%. You still with them. I've done with them. And that's fine. Because if you do high volume, you have to have a conflict. Okay? If you didn't do enough, if you didn't have any complication, that means you did not operate much. As far as your rate is not exceeding that rate. Okay? And you manage your conflict. You know how to manage your complication and act about it. Yes.
Bilateral, what?
Bilateral will give you a suffocation, so the whole glottis will close, so they need a tracheostomy below that, so they could breathe. What about infection? I'll put that.
Why suffocation with the trachea is circles of the cough function?
Because it's a closed area, suffocation because of that you're bleeding.
Yeah.
Because it's a very small area, even 10 ml will be still pressure outside, even if the anesthesia trying to intubate from above, he cannot see. The cartilage will be compressed. It's very small space, very little fluid will compress it, he cannot even see. It's amazing when you had it on table. Where anesthesia, I cannot see, holding laryngoscope, like I cannot see, I'm opening it, oh, it's it. He cannot see, it will be compressed from outside, he cannot see the lumen. So the moment you remove the hematoma, okay, we are in that much, because the very small pressure outside is out from any part. What about infection? Any complication with the infection? What do you think about infection in thyroid? How frequent is the infection? 1 in 10,000, 1 in 50,000. The cleanest surgery ever. You will have thyroid. Nothing, nothing. What's below that? Skin, platysma, vessel. Well, the cleanest surgery ever you will have is thyroid. So the rate of infection, and every day I will infect. So I can't know. When I had an infection for thyroid, I almost have a heart attack. Why? No. How do you get the house getting there? It is behind the thyroid. And right here. That means I have to be sure that I did not injure these two lovely structures and introduce the bacteria in the trachea and esophagus in a very clean area. I'll be scared. I mean, I may have surgical site infection, a simple surgical site infection, because the patient is immunocompromised, breaking the sterility, whatever it is happened, and I will be scared that I'm missing. I may accidentally injure the trachea and esophagus, and the bacteria there made it to sterile area, and this is only the tip of the iceberg. And the exact photograph. So infection here scares the hell out of me. Infection and bleeding here scares the hell out of me. While in general surgery, usually so sad. Develop infection, so sad. Yeah, open and clean and control the wound and give antibiotic and that's it. Oh, bleeding, oh, it's only 500 cc in the chest, guys. A very small hemothorax. That will scare me. It's really scary. So bleeding, infection, injury to the nerve, and parathyroidectomy. Hypergenic parathyroid, hypoparathyroidism. Okay? This is all my lecture. Did I make it clear and simple? Any questions? We good to go? Yeah. So can I will send you the updated one.
حتى الدكتور الماضي
I think you're looking so hard.
Yeah, that's fair.
I thought انا في واحد من اول ابواب الراجل لسه ما خدنا هذه مشكلة هذه شو كان باخذ بس كده ولا نسوي لي بلد يصير عندنا ليش يصير عندنا ليش احنا لازم 40 دقيقة عشان تيجي هذيك تتكلم ساعتين.